I'd like to introduce Ashley Railey from the Paul G. Allen School for Global Animal Health at Washington State University. Thank you, Ashley.
Thank you. Okay. I'm excited today to be presenting on a study that we've done in collaboration with the University of Glasgow and the Nelson Mandela African Institute of Science and Technology in Tanzania on household perceptions of risk as drivers for FMD vaccination. To give you a bit of an overview, the households, we will be looking at the households, and in Tanzania, they are primarily livestock dependent. There's a large population that is engaging in livestock rearing practices, and that they're openly grazing their animals. So herds are coming into contact with each other frequently on a day-to-day basis. FMD is endemic in the country and Eastern Africa more broadly. In Tanzania, it's been shown that 4 of the 7 serotypes are circulating, and that some of these households are experiencing up to 3 outbreaks a year. However, despite this, vaccines are not currently being matched to the serotypes that are circulating. Recent research has been able to look into the types of serotypes circulating and being able to start identifying where these are occurring, when these are occurring, opening up this possibility of targeted vaccination. However, the question remains is that even if we have the technology to bring these vaccines to the households, will the households vaccinate? And what is going to drive the households to vaccinate? When we're thinking about households and their decision-making, a huge part of this is going to be considering the uncertainty that goes with any decision, particularly with health decisions. In the human health literature, this is widely studied, that people are often not vaccinating when rationale would say they should, or when the vaccines are cost-effective. And so really trying to understand what are some of these uncertainties, where are they coming from? If we're thinking as well about livestock-dependent households that are experiencing FMD outbreaks up to 3 times a year, we're also thinking that they're experiencing these shocks and so we need to look into how does the immediacy and the proximity of this shock affect their decisions. And this is also well looked at in discussions of disasters, upcoming disasters, hurricanes, weather, etc., but not so much when we're looking at animal diseases. And finally, when we're thinking about FMD in Tanzania, we have to realize as well that households have vaccinated in the past, but they've had very negative experiences. And again, that could be because we have not been actively matching the vaccines to the circulating serotypes. But we do believe that vaccination will have a positive impact on the households. It's been shown in other diseases in East Africa that vaccinating actually has returns to household health and well-being, and that currently the production losses that households are facing, both with the sale of their livestock, the milk production that they're receiving daily, as well as using their animals on agriculture, that these are significant enough that these could have positive returns to the household. So to get at this vaccination question, we did a survey in 2016 across 2 districts in northern Tanzania, the Serengeti and Ngorongoro, that are on the border with Kenya, and the Serengeti National Park there in the middle in the dark gray. And we had 432 households respond to the questions. As you can see, this is going to be a fairly typical household, farming household. The male leads the household, low education levels, and they're engaging in both off-farm income and crop income, so agricultural sales, as well as, depending on their livestock, for income from selling the cattle to receiving daily milk. Some of them are selling it, as well as all of them are tending to consume it on a daily basis. The average household owns 42 heads of cattle. However, the range was quite large, from 1 to 530, so we're looking at more of a median around 20. And then in terms of FMD, at this time in 2016, 70% had reported having the disease in the past year. However, that has changed in recent years. But only 19% had vaccinated for any disease. And actually, this didn't include FMD, but was for others. To get at the question then, what drives vaccination decisions, we had to keep in mind the fact that households are not currently vaccinating and that the FMD vaccine is not on the market. Therefore, we did a stated preference willingness to pay, which is derived from the individual household's preferences and not the market. We posed to them a hypothetical question that asked, would you pay X amount to vaccinate your cow, one cow? It would last 6 months. If households said, yes, I would pay that amount, we then raised the price and asked them again. If they said no, we lowered it and then asked them at the lower price. This is the double-bounded method that's fairly common in the economics literature. And again, we were really doing this for one cow, so they just had to focus on a price for one cow, and then with a duration of 6 months. To get at this question of risk and how household perceptions of risk might be affecting their vaccination practices, we then looked at the idea that we can have routine vaccination, which would be a biannual, every 6-month vaccination, versus the emergency vaccination. There's an outbreak nearby, would you vaccinate? And so these were two separate questions, but with that same double-bounded structure. The routine then, again, is biannual, and it has this more of a population level protection idea behind it, that if households are actively vaccinating ahead of outbreaks, then they are contributing to population level control. It's lower perceived risk of infection, though. There's not an immediate threat. They don't know if there's going to be an outbreak in the next 6 months. Potentially yes, potentially not. With the emergency, though, we told them there is an outbreak nearby, would you vaccinate? This then induces the spatial and temporal immediacy of needing to vaccinate to respond to the outbreak. It's going to be much more individual focused. They can really only protect their animals at this point versus protecting or contributing to village level control. And this one then has that higher perceived risk of infection. It's nearby. Do you risk trying to protect your animals? Do you risk that they've already become infected? How do you make that decision? Both of the questions were additionally conditioned on vaccine efficacy. So either 50% or 100 households randomly received one or the other of these. And this was more just to get a general idea of having a great vaccine, 100%, it's gonna work, versus there's some question to this, it might not work. An imprecise measure, but getting at what we wanted to do. And then the emergency, that outbreak distance was conditioned on the village level, so around 5 kilometers, versus your neighbor, the person who lives right next to you. To get their predicted values then, what they might be willing to pay, we had to do a maximum likelihood estimator on those two questions, that double-bounded sequence. And this really allowed us to narrow in on what the predicted values might be. As you can see from the graph here, that the emergency has a higher willingness to pay, which is showing us that households are responding, they are sensitive to increased values of risk. They present a higher value as the risk increases. However, along with this, there is quite a spread in the emergency responses compared to those in the routine, indicating that there's still some uncertainty associated with the emergency vaccine. This uncertainty shows up again when we're looking at the determinants of vaccination. We see that with the outbreak distance, that it didn't matter whether households were told it was with the village or with the neighbor, that was not affecting their decision. And this could follow with the fact that households are very much aware of FMD and what happens when there is an outbreak. They are all grazing communally, visiting a lot of the same spots. And because of that, whether it's your neighbor, whether it's your village, chances are fairly high you might have already interacted with each other. We also see, though, that income is a factor, that households are both concerned about the loss of risk or a loss of income risk, whereas their cattle are major assets, they need to protect them, but that having diverse resources is going to help them respond to disease and purchase those vaccines. And then looking back at that efficacy, we see, though, that the male head of households who actually have more experience vaccinating their cattle versus the females who tend to vaccinate more of the poultry, that they are sensitive to that efficacy. They do not want vaccines that are only 50%. They would obviously prefer those of 100. However, increasingly what we're seeing too is that there are concerns that are showing up with that from the education and the source of information that they receive. And that's that neither of these are really showing that households are consoled that these vaccines would work. Instead, there's an uncertainty, there's some doubt that the vaccines are going to be able to perform as well as we would expect them to. Thank you. So to go back to the main question is, how do we increase vaccination uptake? The good news is that from our study on 400 plus households in northern Tanzania, households there do appear to want vaccines. They express an interest in our interviews with them, as well as that's showing up in our quantitative analysis. That comes with a caveat, though, and that's that we need to demonstrate field effectiveness. They consistently told us that the past vaccines they received did not work and wanted to know why they would purchase vaccines if they didn't believe they would work. And so providing better quality vaccines, looking to the supply chain to ensure that we can provide those vaccines to them in a timely manner before an outbreak would be helpful. Part of this then is going to be improving surveillance and household participation. Colleagues of mine are currently looking at predicting outbreaks in space and time. I mentioned previously that one of the papers just came out, and they're currently working on livestock movements and tracking the herds, as well as then thinking about community control. And that disease, and especially FMD, requires the community to participate and make these decisions. And then finally, doing a larger analysis of the quantity of vaccines we might need, et cetera. Thank you all for listening, and thank you to the various participants and funding agencies that have made this possible.